Welcome to this high-yield MRCP revision session. In the next 4 minutes, we'll cover unstable angina, its definition, clinical presentation, investigation, and management, based on the latest European Society of Cardiology ESC guidelines. Unstable angina is a subtype of acute coronary syndrome, ACS, characterized by myocardial ischemia without myocardial necrosis. There's no rise in cardiac biomarkers, particularly troponin, and no persistent ST segment elevation on ECG. Key point: it's differentiated from NSTEMI by the absence of troponin elevation. Clinical presentation: unstable angina should be suspected in patients with one or more of the following features: new onset angina of class 3 severity or worse, crescendo angina increasing frequency, severity, or duration, angina at rest or minimal exertion, recent onset angina, 2 months that is rapidly worsening, post-MI angina within 2 weeks of infarction. Key point: pain may radiate to the jaw or left arm and is not relieved by rest or nitrates as quickly as in stable angina. Investigations. Initial investigations include 12-lead ECG, may show ST depression or T-wave inversion or be normal. Serial troponin measurements, high sensitivity troponin at 0 and 1 or 3 hours, FBC, U and E, glucose, lipid profile, coagulation panel, chest X-ray to exclude alternate causes, echocardiography if left ventricular dysfunction is suspected, GRACE score for risk stratification. Key point: in unstable angina, troponin remains normal, distinguishing it from NSTEMI. Use the GRACE score to stratify risk and guide management. Low risk, GRACE less than 109. Intermediate, GRACE 109 to 139. High risk, GRACE greater than 140. Key point: a GRACE score greater than 140 is an indication for early invasive strategy. Initial management includes aspirin 150 to 300 milligrams loading dose, then 75 to 100 milligrams daily. P2Y12 inhibitor, usually clopidogrel 300 to 600 milligrams loading, then 75 milligrams daily. Anticoagulation, fondaparinux 2.5 milligrams subcutaneously daily, or enoxaparin if renal impairment. Beta blockers unless contraindicated. Nitrates for symptom relief. High intensity statins, e.g. atorvastatin 80 milligrams. Oxygen only if hypoxic, SpO2 less than 90%. Key point: dual antiplatelet therapy and anticoagulation are cornerstone treatments. The timing of coronary angiography is guided by risk. Immediate, less than 2 hours. Hemodynamic instability, ongoing chest pain, life-threatening arrhythmia. Early, 24 hours. Dynamic ECG changes, elevated risk, e.g. GRACE greater than 140. Elective, stable, low-risk patients. Key point: do not delay coronary angiography in high-risk or unstable patients. Let's summarize the high-yield facts. Unstable angina equals ACS without troponin rise or ST elevation. Always exclude NSTEMI with serial high sensitivity troponin. ECG may be normal. Dynamic changes carry prognostic value. Use GRACE score to guide intervention. Aspirin plus clopidogrel plus anticoagulant plus statin equals standard therapy. Early invasive strategy improves outcomes in high-risk patients. Thank you for watching. For more focused revision, visit passonexam.com, your trusted resource for MRCP success.